of supporting ventilation and oxygenation. Mechanical ventilation. Indications for mechanical ventilation: apnea, hypoventilation, acute respiratory acidosis. Intraoperative positioning limiting respiratory excursion, e.g. prone, Trendelenburg, required hyperventilation to lower ICP. Deliver PEEP, increased intrathoracic pressure, e.g. laparoscopic procedure. Complications of mechanical ventilation: airway complications, tracheal stenosis, laryngeal edema, alveolar complications. Ventilator-induced lung injury, barotrauma, valatrauma, atelectatrauma, ventilator-associated pneumonia, nosocomial pneumonia, inflammation, autoPEEP, patient ventilator asynchrony. Cardiovascular complications, reduced venous return, secondary to increased intrathoracic pressure, reduced cardiac output, hypotension. Changes in peak pressures in ACV and tidal volumes and PCV may reflect changes in lung compliance and/or airway resistance. Patient may be getting better or worse. Positive end expiratory pressure, PEEP, positive pressure applied at the end of ventilation that helps to keep alveoli open, decreasing VQ mismatch. Used with all invasive modes of ventilation. Tracheostomy. Tracheostomy should be considered in patients who require ventilator support for extended periods of time. Shown to improve patient comfort and give patients a better ability to participate in rehabilitation activities. A11 anesthesia, neuromuscular complications, muscle atrophy, increased ICP. Metabolic, decreased CO2 due to hyperventilation, alkalemia with overcorrection of chronic hypercarbia. Ventilator strategies, mode and settings are determined based on patient factors, e.g. ideal body weight, compliance, resistance, and underlying reason for mechanical ventilation. Hypoxemic respiratory failure ventilator provides supplemental oxygen, recruits atelectatic lung segments, helps improve VQ mismatch, and decreases intrapulmonary shunt. Hypercapnic respiratory failure ventilator augments alveolar ventilation, may decrease the work of breathing, allowing respiratory muscles to rest. Modes of ventilation: assist control ventilation, ACV or volume control, VC. Every breath is delivered with a preset tidal volume and rate or minute ventilation. Extra controlled breaths may be triggered by patient effort. If no effort is detected within a specified amount of time, the ventilator will initiate the breath. Pressure control ventilation, PCV. A minimum frequency is set and patient may trigger additional breaths above the ventilator. All breaths delivered at a preset constant inspiratory pressure. In traditional PCV, tidal volume is not guaranteed, thus changes in compliance and resistance affect tidal volume. Synchronous intermittent mandatory ventilation SIMV. Ventilator provides controlled breaths, either at a set volume or pressure depending on whether in VC or PCV, respectively. Patient can breathe spontaneously, these breaths pressure supported. Between controlled breaths, pressure support ventilation, PSV. Patient initiates all breaths and the ventilator supports each breath with a preset inspiratory pressure, useful for weaning off ventilator. High-frequency oscillatory ventilation HFOV, high breathing rate, up to 900 breaths min in an adult, very low tidal volumes, used commonly in neonatal and pediatric respiratory failure. Occasionally used in adults when conventional mechanical ventilation is failing. Non-invasive positive pressure ventilation (NPPV), achieved without intubation by using a nasal or face mask. BiPAP, increased pressure, like PSV on inspiration and lower constant pressure on expiration, i.e. PEEP. PAP delivers constant pressure on both inspiration and expiration. Table 3. Causes of abnormal and tidal CO2 levels. Hypocapnia, decreased CO2. Hyperventilation. Hypothermia, decreased metabolic rate. Decreased pulmonary blood flow, decreased cardiac output. Technical issues. Incorrect placement of sampling catheter. Inadequate sampling volume. VQ mismatch. Pulmonary thromboembolism. Incipient pulmonary edema. Air embolism. Hypercapnia, increased CO2. Hypoventilation. Malignant hyperthermia, other hypermetabolic states. Improved pulmonary blood flow after resuscitation or hypotension. Technical issues. Water and capnography device. Anesthetic breathing circuit error. Inadequate fresh gas flow. Rebreathing. Exhausted soda lime. Faulty circuit absorber valves. Low bicarbonate. Toronto Notes 2021. Monitoring ventilatory therapy. Pulse oximetry. ECO2 concentration. Regular arterial blood gases. Assess tolerance regularly. Patients who develop a pneumothorax while on mechanical ventilation require a chest tube. Causes of intraoperative hypoxemia: inadequate